Hello and welcome to the Human in the Machine podcast, the podcast about all things HCI. As ever, I'm your host, Professor Ben Cowan. This episode is all about technology acceptance and healthcare. We're joined by Dr Camille Nadal from Trinity College Dublin. Camille is a leading researcher in the area of HCI and healthcare technologies and is a member of the ADAPT Centre here in Ireland. She's won Best Paper Awards at ACM CHI for her groundbreaking work on merging theory with practice when engaging with designers looking at healthcare technology acceptance models. I'm a huge fan of Camille's work, and I think the talk illustrates how HCI theory can be used to positively affect design practice. Again, if you like the podcast, please don't forget to review us and follow us, and if you want to get in contact with us, you can by emailing us at humaninthemachinepodcast@gmail.com. I also have to apologise a bit for the audio quality here. We've had to do some audio cleaning to reduce some noise in the background during Camille's talk, which interrupted what Camille was saying in the audio. So I hope it's still okay for you to listen to, so please sit back, enjoy.
Thank you very much, Ben, for the introduction. Hi, everyone. So today my talk will be on user acceptance of health and mental health technologies, which has been the focus of my PhD research. So I'm now a postdoc. So today I'm going to go through, I'll start by giving you, I suppose, a definition of user acceptance, because this is something that's quite abstract when you first hear about it. So then I will talk you through a concrete example. Then we'll talk a little bit about the theories, because there's many theories on user acceptance. So try to kind of clarify a bit that, and then see how these theories are actually used in practice. Then I'll talk a bit about designing for user acceptance. And finally, I will end with evaluating user acceptance. So when the technology is produced, how do you actually evaluate how users accept it into their life? And so for these last two parts, I will talk you through case studies, which I've done in the digital health context and the mental health context. So to kick off, let's start with the definition and example. So technology acceptance is defined as how individuals perceive a technology and how this perception leads them to use it or not. So in this definition, you have the notion of, I suppose, distant perception. So how you perceive the technology before using it. And then more like perception through use and experience with technology. So when you start using it and as you interact with it, you develop a different perception. So something that's very important is that user acceptance and this image of our view of the technology that you are forming, it evolves over time. So this is something to be considered as like a dynamic process as opposed to something that's static. So to give you an example, and because user acceptance research is concerned with identifying facilitators of acceptance, but also barriers of acceptance. So we are going to see what these means in like a real case of a technology. So I'm going to bring you back to 2020 and in the midst of the COVID-19 pandemic. So you might have come across one of these ads, kind of encouraging you to download the COVID tracker app. So if we look a bit at this picture here, so, we can see a bit of like a theme going on with sky, clouds, a rainbow, and the app there is, kind of presented as the sun in the picture. So it's really positive, like a positive image, right, that's trying to give off the app. There is this text, be more than 1 in a million. So it's really talking about or touching on your perception of yourself, doing something good. And so this is really about self-image and trying to do something good in this context of pandemic. And then we can, if we look a bit more at the text there, so it says it's encouraging you to download the app to protect yourself and those around you. So this is really talking about, okay, it's not just doing something for yourself, it's also doing something good for the community, your family, those around you. So there is this notion of social pressure or social influence, something that's going to push you maybe to use the app or download the app that's coming from other people. being around you. Then we can notice here as well at the bottom right, the HAC logo and the Government of Ireland logo. So there is this notion of the app is endorsed by institutions that people would, I suppose, generally trust. So this is talking to the notion of trust and building trust into the app. If you, how you relate to these institutions will also impact how you perceive the technology there. And finally, at the top right there, you can see, I suppose, an image or the logo used for the COVID-19 virus. So this is kind of reminding you, okay, this is about the COVID-19 disease. And so this talks to the notion of perceived threat, how dangerous you're perceiving COVID-19 is, and kind of reminding you, okay, this is the threat that's there. So all of these factors might facilitate your acceptance of the technology, might push you to download the app, but of course so it might be enough for some people to just download the app, just seeing all of this, but there's also question as to what does the app actually look like? Is it easy to use? What does it do, etc. So that might not be enough for some people to actually go take that step and download the app. So if you do decide to download the app based on seeing this and all of these factors, then we are kind of moving from this pre-use acceptability into a more like initial use, so the first interactions that you will have with the apps. So again, if we look at it there, this is a screen from like a first screen after you have downloaded the app, so you can see some stats or some numbers, how many people have checked in today. There's some text saying, okay, this is today's fight. So it's really kind of emphasizing this community of users. This is a common effort towards like surviving or getting through in the context of the pandemic. So this is talking again about this social pressure, right? Then we can see at the bottom the number of new COVID cases. So this is again relying on the perceived threat and the way you perceive this, I suppose this information is also framed by your own health beliefs and concerns, how you perceive yourself to be vulnerable or not, or others around you. Are you concerned about catching COVID-19, about transmitting it to other people, things like that. And so then the last one is, as you start interacting with the app, there is, of course, the notion of usability that's coming into play. So you might find the app easy to use or not. There might be, I don't know, things that are like obstacles to the use. So all of these factors, again, are going to influence how, or to change the image that you had of the app in a positive or negative way, right? But if you do decide to continue to use it, so this is then when we move on from initial use acceptance towards more like long-term or sustained use. So this is an example of a screen where you get a close contact warning. So an exposure notification that says, okay, one of your contacts has tested positive to COVID-19. You have been queued for a phone call and we will try to call you as soon as possible. So here, something that is likely to be important will be the reliability. Do you perceive this as being accurate? Do you actually trust the app in like accurately detecting that your contact have been testing positive and accurately detecting risk? There's also the notion of, again, your beliefs and concern as to how threatening that is to you and for your health. And so basically all of these factors that you see are going to influence how you perceive the technology and your uptake of the app and your use. Are you going to keep using it, or are you going to abandon it because some factors are not, I suppose, aligning with what you would like the app to do? So this is really like the timeline, I suppose, of acceptance. So from pre-use acceptability into initial use acceptance, so the first interactions, and up to a more like sustained use. And these factors, as I mentioned, some of them can can be maintained over time, so they can appear and then kind of maintain themselves. For example, health belief and concern can be one that is important at different stages, or they can just be, for example, at the start and impact your perception at the start, but then not necessarily be important for your user journey later on. So again, just to keep in mind that this evolution is something that is happening and needs to be considered. So in terms of the theories, as I mentioned, there are quite a number of them. That's because user acceptance has been studied for over 3 decades in the field of HCI. So there is loads of models that have been developed. Some models have been validated, but of course it takes a lot of effort and resources to do it. It's more complicated to validate models in certain contexts, for example, clinical settings. So as a result, some models are not validated. They have been produced because researchers didn't find validated models that were adapted to what they were trying to do. So they typically extended a validated model they found to be more tailored to their research context, to their research population, and so on. So to give you just a bit of history as to the field of user acceptance research. So it all started with an interest on technologies for the workplace. That's because the primary interest of the field was how do we get people to uptake technology and to keep using it, basically, especially in the workplace context. This was meant to improve productivity, efficiency. So this model that you see here is the technology acceptance model, which is the first acceptance model produced by Davis in 1985. So the core concepts there are linked to user motivation. So you have perceived usefulness, attitude towards using, and perceived ease of use. And all of these will lead to use of the system, or a certain use or not of the system, actually. Then you can see on the left-hand side that it is actually the design features of the technology that will impact how you perceive its usefulness or its ease of use. And so this is kind of missing, I suppose, the human aspect of it. So it's not just about how the technology shapes your perception of the technology itself. There's a lot more going on into how who you are as a person, where the environment you evolve in, the people that might influence your decision or your thinking. So this is not reflected in this diagram, right? This could be, or a hypothesis could be, that employees, I suppose back then, who had a desk job, they typically had the same kind of profile, they were educated, they might not be as diverse, I suppose, as populations that we might be interested in now or studying now. So what happened then was this model is still used as like the core model for many of the theories, but it has been extended by Davis himself, by his colleagues, as they got like a better understanding of the different processes that went into user acceptance. So it went from like a focus on technologies for the workplace towards more technology used for everyday life, which is kind of the way technology has evolved, right? From a more formal use, professional use, into like everyday life. And then what I'm going to talk a bit more in detail now is technology for health. So this particular domain of healthcare, like you can imagine, the priorities and the concerns are different. The populations are different. Users are often more vulnerable. Technologies might be more invasive, if it's for diagnosis, for treatment, or even just for monitoring people. So the concepts will be different. Technology will also deal often with sensitive data. And sometimes you want the user to use the technology long term. So when care is provided through technology, if the person does not accept the technology, or if the technology is not acceptable to the user, then it causes a problem that the person might not have access to care. If this is the only option to get care and the person is not accepting of the technology, then, they will miss on the opportunity to have access to care. So if we take this example there of someone with diabetes, I suppose the traditional way of monitoring glucose would be like finger pricking. And an alternative here that's more recent is having this kind of implant on your arm that would automatically monitor your glucose level. Obviously, this is way more invasive than the finger pricking. There's loads of advantages. For example, it's not painful. You don't have to carry the device with you. It is actually on you, and then you have the app. It can be more accurate, but there can also be like negatives it can be less accurate, I suppose, if it's not placed properly. So there is like pros and cons, but at the end of the day, this will have a real impact on the person's life. So all of these factors, the consequences of all of these factors are, I suppose, more important in the context of health, because the consequences will be on the person's health, quality of life, clinical outcomes. So this is something that we really want to get right. In terms of the theories of user acceptance for health, there is different models produced. This one is the health technology acceptance model. I'm presenting it here because I'm going to be relying on it later on in the talk. So what you can see here is the core of the model is actually a Davis technology acceptance model. And then they have extended it, and instead of having just design features at the start, they have like antecedents based on different categories. So we have antecedents linked to health, linked to information, and linked to technology. So it's not just technology. There is more like individual, social aspect to it. So we have health status and health beliefs and concerns, which I mentioned earlier. This feeds into perceived threat. Then we have subjective norm, so kind of social pressure, community, competition, things like that. The technology reliability. And the last one, self-efficacy. So adding these kind of antecedents, it brings the human more in the loop, I suppose. But also it kind of extends our view of, okay, this is not just about the technology. It is about people using it or people being impacted by it, how they perceive the world, how they perceive themselves, how others might influence their decisions, how their context influence their decisions, their own ability towards using technology. Are they anxious about technology? Things like that. So, how these models typically work when you decide to evaluate a technology is you would have, because they are validated, they have been validated through using questionnaires. So you would have for each factor a set of questions that you can use then to evaluate how your technology is doing compared to these different factors. If we move on now to the mental health kind of context. So we have all, this is just, I suppose, a snippet of all the models. There's many more. These ones are the validated ones, part of it actually. Yeah, I see someone counting. I think there is like 16 validated ones, and then there is a bit more of non-validated ones. So on one hand, we have this evolution of technology, but this of theories, but the evolution of theory is not matching the pace of the technological development and the different context of use of technology. So basically, the theory development is slower than technology development. And this leads me to talking about mental health. So for talking about acceptance of mental health technologies, there is no validated theory. There is no validated models. So again, probably due to that. So technology for mental health, this is something that's quite new. And the theories are not evolving, I suppose, fast enough or to match the kind of new context of use of technology for the particular case, mental health. There is also the question of validating theories. So there might be like ad hoc theories built just for one study, but not reproducible for others. So validating theories in clinical context is something that's quite difficult. Just getting access to clinical populations, that's something that's more difficult than just evaluating something with employees, for example. So now if we look at practices and how those theories actually are actually used into practice. So this is based on a review I've done on mobile health literature. So I looked at how researchers define acceptance and talk about acceptance. So they actually refer to acceptability, acceptance, and adoption interchangeably. Then we can see that these are the terms or the definitions they were given for each term. And so most of the time, acceptance is equated to one particular concept. So typically perceived usefulness came up as one of the top ones, user satisfaction, intention to use, and usage. So instead of having this kind of broad or set of factors, people are just reducing it to one. And you can see it's actually a different one. Like there's loads of different interpretations of what acceptance mean. So this result on like some kind of confusion in the field as to the terminology, the definition of user acceptance, but also this has repercussion as to how do you evaluate something that you actually like you're actually wrong on the definition, or not wrong, but your definition is very narrow. So you're going to evaluate only one factor when there is actually a set of factors you should be looking at. So there is a gap between theory and practice in that sense. So one of the contributions of my work was this technology acceptance lifecycle, which tries to clarify the terminology. So taking the terms and placing them on the timeline. So we have pre-use acceptability. So before the person has used the technology, then initial use acceptance, so the first interactions, and then sustained use acceptance. And then this notion of adoption, that's something that's like a time point somewhere happening during the sustained use acceptance stage. And so this timeline is something that wasn't there before. We had models, but they are actually static. And so placing these terms on giving them a temporal dimension, this was really needed to get this understanding that, okay, user acceptance actually evolves over time. And something that came out as well was that user acceptance is rarely considered at design stage. So you can imagine that that's something that's quite problematic, because you're only looking at acceptance when the technology is out there, implemented, launched, produced, people are using it, people are relying on it. So this is something we should be looking at design stage. And I'm going to talk a bit about that more in the next section. But yeah, typically, because we have this large set of theories, this confusion as to the terminology, it makes it really difficult for designers to know what to do. So in terms of designing for user acceptance, to design for something, first you need to understand why that's important, and then you need to kind of know how to go about it. So do you actually need to review all the literature and then pick out one model or one theory that is more adapted to your study? like we can imagine nobody can actually do that unless you're a PhD student and you have that time, dedicated for literature review. Designers won't do that. They won't review like thousands of publications just to do this particular piece. So what we tried to do was to bridge the gap between theory and practice and facilitate application of theory into practice. So this was a work in collaboration with Kevin. So we designed this technology acceptance toolkit, which is a set of playing cards. And so this is really to make the theory accessible to designers and to give them a common language, common understanding of what the factors are, and facilitate application of theory into practice, because that's a tool they can use kind of on everyday practice very easily. There is also, it also supports like reflection on the temporal aspect to it. So I'm going to go a bit deeper into, I suppose, the history of the TAC toolkit. So these are the models that are represented in the toolkit. They are validated models. Some of them are kind of original models of user acceptance, so they're more for general technology. Some of them are more health related. And so so we had curated or tailored the factors that were in these models. All of them were integrated, except those that were relevant to technology for work. So for example, work performance, this one was not integrated because the TAC toolkit is focusing on digital health, digital mental health, which is kind of where the gap, I suppose, is. So yeah, these are the cards. So there are 16 cards representing each a factor of acceptance. So we kept the categories which were in the health technology acceptance model. So in red, you can see the health cards. In orange, you can see the kind of individual social cards. And in blue, we have technology cards. So on each card, you can see the name of the factor. We have put in their icons to make them easy to learn and easy to memorize. And then on the back of each card, you've got a series of questions. So the first question represents the definition of the factor. So this one is social pressure. So the question here is, how does society influence users' health decisions? And then we have different questions prompting reflection, designers' reflection around different aspects of the factor. So for example, here, to which social pressures are users exposed? Are these helpful? In what ways do our design choices lighten or lend weight to these pressures? Where does the technology place responsibility for users' health? And etc. So this is really to push designers to think about the factors in the very practical way, I suppose, and to foster that understanding of different aspects of user acceptance and not just focus on one. So the TAC toolkit was evaluated in a case study. So we had 21 digital health designers evaluating it and working with it through a design workshop. They were divided into interdisciplinary teams. So in each team we had 3 people. One was a HCI expert, one was a clinical psychologist, and the last person was a designer with another background. So for example, engineering or project manager, things like that. So we were trying to reproduce the interdisciplinarity that we usually find in like design teams working on digital health products. And so the workshops happened over the COVID pandemic. So they were actually hybrid in the sense that I had posted a physical set of cards to each participant to use in their own space, and then they joined the workshop remotely. And so I'm going to talk a bit about like how this remote collaboration happened. So they were designing remotely, but with the cards as well, the physical cards with them. And then, so we analyzed the workshop conversations, and we also had a post-workshop individual interview to kind of delve a bit deeper into their individual experiences of designing with the toolkit. So in terms of what happened, what was the design activity, so they were given personas to pick from. So one of the persona was Ali, an elderly person living with depression and struggling to remember to take their medication. And then associated with each persona, they were given a temporal scenario. So for example, for Ali, the scenario was a medication reminder app. And these scenarios are temporal in the sense that they describe instructions, or they describe the user's story from introduction of the technology throughout the first interactions and up to after a year of use. So you can see here the person starts, they seek advice, they choose technology, they have their first interactions, and then we move on to next day, a week later, after a month, after 3 months, after a year. So this is reproducing the 3 stages of the user acceptance journey, but kind of taking a more fine-grained take. And so for each temporal milestone, then you have a little scenario snippet. This is the virtual board with which the participants worked or designed remotely. So they had at the bottom their virtual version of the cards, so they could drag and drop them. You can see in the middle section there the temporal milestones, and so for each of the little snippets of scenario, they were asked to reflect on which factors were influencing the user in that particular scenario. And then they were asked to write why those factors are influencing here, why do they think they're at play here, and then what actions they could take in terms of design or in terms of framing, introducing the technology to facilitate user acceptance. So in terms of the findings from the workshop conversations and the interviews, so we found that the toolkit was actually very efficient at bridging this theory-practice gap. So these are the overarching themes there. It also helped people design for long-term acceptance, and taking this temporal scenario, people could actually reflect on different stages of the user journey and see how the factors they had selected at the start or they thought was at play at the start might evolve, might be maintained or might disappear. And then it really helped them have these conversations. So discuss user acceptance together as a team, regardless of their background or expertise. So just to dive a bit deeper into the first one, so bridging theory and design practice. So the toolkit really helped them see acceptance as something that is dynamic and a process that is linked to the user journey. So someone commented it really helps to refocus the design in a user-centered perspective all along, going from the short term to the use and adoption of the device in the long term. Something that I mentioned at the start is that acceptance is something that is often quite abstract. And so the toolkit really helped to bring a concrete dimension to each of the factors. So someone commented there, without the moderation of the cards, well, I think, when I think about user acceptance, well, I think about it at a very abstract level. The toolkit helped navigate our thinking to one certain area in depth. So working with the toolkit also helped them get a deeper understanding of each of the factors of acceptance and what kind of issues might happen throughout the user journey. Also that each factor can be either a facilitator of acceptance or a barrier. I was not familiar with all these factors. My spectrum and my way of speaking changed around that topic, was one of the comments. Then because it was like using playing cards, for a professional design activity. It actually was a playful experience, so people commented it felt like playing a board game. They were also quite satisfied with being able to leverage a complex issue in just an hour and a half. So someone commented there, I have come across 15 theories myself, a set of generalizable and standardized questions that could be asked for general constructs that are suggested in those theories. Is really a useful tool to have. Then talking about designing for long-term acceptance, something that is important is reflecting on your design choices and how design choices that you make will impact the user trajectory. And this really supported that. So the only, I suppose, challenge that people had was visualizing future user experiences with technology. So someone said, it's very hard for me to take that whole year-long view. They asked what's getting too fine-grained and on some things on a user trajectory that's more sketchy. So trying to think of someone using your technology after a year that it's been deployed, I suppose, and trying to anticipate or imagine the issues they might have or how, what factors is impacting their experience. This is something that's a bit too fine-grained for people at the moment. And so we might want to find or to think about some tool or some means to support this kind of work, I suppose. Then people talked about using that in their future practice. So this was a clinical psychologist commenting that they would have these cards to hand in that kind of design phase to ensure they're having the right conversations. Since publication and since the toolkit was developed, it has been used in 4 different research groups, 2 in Ireland, 1 in Northern Ireland, and 1 in Denmark, and it has been used for design practice and then for teaching in 2 Irish universities. So this is something that's actually easy to use in practice and that people don't feel intimidated by it. They can just have it on their desk. And some people comment, I have your type toolkit on my desk and I can just open it and use it, whenever I want to reflect on particular technology I'm working on. And so then something else that we observed was using the toolkit actually led the designers to produce more ethical design. So we encountered in the design actions they had proposed, they were supporting principles of transparency, autonomy, accessibility, and privacy. And then something I'm really shortening it for the purpose of time, but this is actually a major point. Having the ability of having these conversations, having the terminology, having a common language to just have these design conversations is something major, and the Tech Toolkit really supported these discussions. Someone commented that cards are like your invitation to join the party. All of us shared an understanding of the factors. And so that's something that's critical. If you're trying to design for something, in the context of interdisciplinarity, and you have all these stakeholders around the table, you need like a common language. You need common terminology to be able to discuss things, but also to create an environment where every stakeholder feels valued, feels they can have, they can take part in the conversation and they can contribute as much as the others. And so the fact that they also had a physical set of cards, this really kind of leveraged the field and help them take their time, look at the factors, and then discuss them with their teams, as opposed to have one person, probably more like an expert, dominating the conversation. So in terms of takeaways for this study, so when designing for user acceptance, the first thing to do is really understand the different factors and how these factors might facilitate or impede acceptance. Then you need to really see it as something that's dynamic. So designing for one particular point is not enough. You need to consider the user journey as a whole. And then using a common language, getting everyone involved and giving everyone a common language to have these conversations. But something to keep in mind, theories are constantly evolving. There's new context of use, there's new technology being developed every day. So theories have to evolve, and they are evolving. So we always need to reduce that theory-practice gap, right? There's new factors of acceptance that might be uncovered. For example, factors linked to sustainability, ethicality, things like that. So we will need to revise theories. We will need to adjust design practice in consequence. And then, again, designing for future user experiences is challenging. So we need to find ways, as like future work, I suppose, to make that easier for designers. So this brings me to the last part of my talk, which is around evaluating user acceptance. So for this, I'm going to talk through a case study which was conducted in the UK. So this was with patients, NHS patients. It was a collaboration with SilverCloud by Amwell, which is a provider of digital therapy, so online therapy supported by human supporters. So just to give you a bit of context, so the idea is to evaluate user acceptance of a new technology. So in that case, the new technology was a self-monitoring app on smartwatch. So self-monitoring, just to give you a bit of background, that's a task or an activity that's often used in therapy. So people would be asked to keep record of different events in their life, so their mood, their sleep, their physical activity, and then try together with their therapist to identify patterns. So how their sleep is maybe influencing their mood, how their sleep or physical activity, diet, medication intake, how all of that interacts. So typically it would be done on a paper journal. But then, like, in recent years, that has moved on to, like, more smartphone, mobile-based approaches. So you have self-monitoring apps. And so there is positive to that. So you can self-monitor in the moment. So it would be potentially more accurate. But there is still kind of a burden to doing that. And there is still a perceived stigma, particularly for the male population. There would be a bigger stigma in terms of being involved in like a mental health program, or just self-monitoring their mood, etc. So the smartwatch is actually a good candidate for providing this kind of intervention. It is very close to you, right? So it enables immediate, discrete, private interaction. But there is very limited use in like clinical context. So patient acceptance of this kind of intervention on smartwatch is actually unknown. So this is the smartwatch app that we wanted to evaluate. So on the first screen here, you can see there's like a pop-up notification where the user can pick weather icons, so that would match their mood. So sun, cloud, rain, etc. Then they could pick what they thought affected their mood: sleep, exercise, medication, diet, etc. And then on the last screen, you can see a visualization of their moods alongside their sleep pattern, bedtime, and physical activity. So in terms of what was down to the user and what was down to the smartwatch, the user was doing the mood monitoring manually through this little notification there, and sleep and physical activity was automatically recorded by the watch. So again, in an attempt to lower the burden placed on users. So this app was provided or was intended to be provided in the context of digital therapy for depression. So the intention was that it would be used by a clinical population, But yeah, acceptance is unknown, and so this is really something you want to investigate before actually putting that, in the hands of people or on their wrist. So as I mentioned earlier, evaluating acceptance of health technology, that's something that we have theories for. We know what factors might influence it, so we know where to look and what to measure. In terms of mental health, again, there is like a gap, so we will have to work around that. But what we want to do is really identify what might facilitate user acceptance and what might be obstacles. And we also want to evaluate the evolution of patient acceptance over time. So the digital therapy program is an 8-week program. So we had to think in terms of, okay, we want to measure acceptance, but when do we do that? What time points do we do that? So pre-use, that's something that's quite easy. Day 0, before they even get the smartwatch app in their hands. Sustained use, end of the program, 8 weeks. Initial use was a tricky one. And because, again, this was in the context of the COVID-19 pandemics, we were literally posting Apple Watches to people with the app installed on them. So we had to allow for them to receive the smartwatch and start onboarding the digital therapy program and have their first interactions. So this is how we decided on the 3 weeks kind of time point there. So in terms of the measurements, we relied on the health information technology acceptance model, which I presented earlier, for creating acceptance questionnaires. So these would be like validated questions we had given people at the 3 time points. And then because this is health related, we have theories or models that are not validated for mental health, but they're still worth looking at and exploring. So this is why we also looked at demographics at the start, so pre-use, how people, demographic characteristics impact their perception of the technology. And then we had at the very end more exploratory questions, often open-ended, to get really like a deeper insight into their lived experience with the technology. And finally, we had interviews to kind of further this understanding. And what happened was, during interviews, people would typically refer to the 3 different stages. So when I started using the app, and, kind of more sustained use then. So in terms of the study settings, so again, this was partnership with an industry partner. This is really important to give you access to people and clinical populations. Like without partnership with either the mental health care provider or I suppose a health entity, it is like you just don't have access to clinical populations. And so because of the sensitive nature of the project, we had to apply for ethics approval. So that was done through the NHS Health Research Authority. And then we had, so this was kind of remotely coordinated. So we had 15 NHS professionals on site recruiting participants for us. So we had to train them. And then 69 patients were recruited over several NHS sites. Then we had participants randomized into 2 groups. So people who had just access to the digital therapy program as usual, and people who had the program as usual plus the smartwatch. This was with the intention of assessing feasibility, which is something else that's very important in that kind of when you're thinking of deploying such intervention, but I'm not going to talk about this in this talk. We're going to stay focused on user acceptance. So in this slide, you can see the questionnaire that we used, the acceptance questionnaire, and how it relates to the model. So for each factor of the model, we had a couple of statements. So for example, for perceived threat, we had, I'm strongly concerned about my mental well-being. I would make efforts to manage my mental well-being. And I think that keeping track, that's the next one, perceived usefulness. I'll read it anyway. I think that keeping track of my mood with the watch app is useful in managing my mental well-being, etc. So for each of the statements, people would have a Likert scale from strongly agree to strongly disagree. And this would then help us calculate a score. And so in terms of, just to mention as well, when you have this kind of longitudinal repeating measurements, you have to get people engaged, and actually answer your questionnaires. So that means that we had to email the questionnaire to people, but for that particular initial use stage, we had to have them involved in a timely manner. So we couldn't, open the questionnaire until the end of the study, because that would then slide into sustained use. It wouldn't be just initial use. So we had to kind of close the questionnaire, for example, from 3 weeks to 4 weeks, and that was it. Getting people to engage in this kind of research measurement in a timely manner, that is another challenge. In terms of the questionnaire scores, so as you can see here, throughout the 8 weeks, they remained over 70%, so that would be quite high. And there was no statistical difference between the 3 time points. So this kind of eliminates, the idea that the technology is not accepted, it's risky, etc. And people have a generally high acceptance of it. But obviously, having just this does not give you any insight as to how people have experienced it, their lived experience. So that's something that we look further into, but this is really an argument for using mixed methods and not just having a questionnaire with a questionnaire score, and having really open-ended question interview, getting people to share with you what their experience was. So in terms of demographics, I'll go quickly on this, but the only difference that we found was people who were married or in civil partnership were more likely to have a higher score than people who were single. So, and a hypothesis could be that they have some kind of social pressure or social support going on, and that other people might not have, and that kind of facilitated acceptance. But again, that's not validated, that's just an insight from the study. And then we looked at usage. So people with the smartwatch could log their mood either on the watch or on the usual desktop or mobile app. And what happened is that they really logged their mood on the smartwatch much more than they did on the desktop and mobile app. So there was significant difference here. So we can see that this high acceptance actually translated into usage. In terms of the temporality of it, so this is a comparison between people who had access to the smartwatch monitoring and the control group who didn't. And so you can see that people with the smartwatch tended to log their mood throughout the 8 weeks. Mostly everybody engaged with it at least once, as opposed to the control group where more people didn't engage at all. And you can see that no one actually logged any mood for throughout the 8 weeks. So there is a difference in terms of engagement over time as well. So now that we've gone through the quantitative findings, let's look at the qualitative findings. So in terms of what facilitated acceptance and what were the barriers. So these tables summarize the different themes so the patterns that were going on, or that we identified in the interviews, and open-ended questions. So we have themes like, I want to get better. It helps me check in with myself. And then we have barriers like, the app is not personalized enough. I find it difficult to change my habits, etc. And then we have related these themes to the model's concepts, so perceived threat, usefulness, etc. And also to the timeline. So when do these patterns emerge? When do these patterns when were they identified in the user journey? Was it at pre-use, initial use, sustained use? So I'm going to go through a few of them. So in terms of facilitators, I want to get better. So typically people who were concerned about their mental well-being were more likely to be more accepting of the app. So I should give a little disclaimer here, some text. So it is about mental health, emotional distress sometimes. So just to give you a bit of disclaimer here. I start again. I would like to give it a try, as I've tried everything with my best abilities, and I am scared when the depression is going to strike me again. So being concerned about your emotional distress, this is something that really pushed people to try this as like a last resort kind of thing. It helps me check in with myself. This is related to perceived usefulness. So typically the watch notification gave people some time to pause and reflect on their feelings. So when I got the reminder in the morning, I wasn't sure how I was feeling. So when it asked me to record my mood, I actually took 2 minutes to understand how I'm feeling. I would carry one problem or the other, but now if I know I'm in a bad mood, I know that I have to lay low, just let it pass, and it's going to be okay. And having this time to kind of pause and reflect and identify how they were feeling, this also impacted on their relationships. So someone commented, as a mother, she would often kind of snap at her kids or her partner, and just having this opportunity to pause and just acknowledge how she was feeling, that really changed, or she could then adjust her behavior and be more aware of her interactions with others. So the next pattern, it encourages me to adopt healthier habits. Again, this is perceived usefulness. So one thing that we wanted through this app was to get people to become aware of patterns between their sleep, physical activity, and their mood. So when I wasn't getting enough sleep, or if I was having too much sleep, I did actually notice that it was making me feel a bit grouchy or irritable the next day. And that's something I never kind of linked together. So it helped kind of breaking that cycle and identifying patterns and then adjusting behavior. Behavior change was a result of this. I don't fear the judgment of others. So this is linked to attitude and this is linked to stigma. This was mostly mentioned by male participants who again were saying the stigma is stronger for men, even though, there can be stigma in different cultures. This is what came out of the interviews, that for men it's a little bit more stigmatized, or at least the people we interviewed, that was the case for them. So someone commented, we were out with friends this past weekend and I got some reminders and I felt very comfortable just kind of quietly logging it and just taking a second to check in with myself. In terms of the barriers, so there is this kind of notion of how your self-efficacy, I suppose. How efficient are you going to be using this app? So I don't believe I can use the smartwatch, was what came out from the interview. This is linked to perceived ease of use. I don't think that I'm the best for something like that, as I'm not good with technology. This was a comment by someone who decided not to take part because it was on smartwatch and because they just felt they wouldn't be able to use it at all. And then someone commented, I don't have a laptop and only using this annoying small screen iPhone. I don't know how to make the smartwatch work, as I struggled with technology, but willing to learn. Then there were some comments on the smartwatch disrupting the person's routine. So someone commented, I couldn't really switch off having the watch on my arm and seeing it at all the time. Sometimes I felt a bit drained and like I wasn't actually connected to the real world. So this is something that it is important to anticipate, right? Because this is technology for mental health, but technology overuse or technology use in some cases can really have a detrimental impact on your mental health. So obviously we would want people to be able to connect with the real world. So this is something that needs to be addressed. And then because we talk about behavioral change, the kind of opposite to that is I find it difficult to change my habits. So resistance to change, I suppose. This is linked to attitude. So someone commented some days, I just don't put the watch on as I'm just being lazy. So this comment about being lazy here, this also, this is linked to people's self-perception, but also others' perception that depression sometimes is just someone being lazy, someone not getting out of bed, someone not willing to just go out and take a walk. So having this kind of narrative about oneself, it's really impacting how the person views themselves and their mental or their emotional distress, or maybe that it's not a real symptom, I suppose, of depression. How they view themselves impact how they then relate to the technology. So yeah, just to keep in mind that this kind of perception, this is a symptom of depression, like seeing everything in a negative way, being told you're being lazy, but this will actually impact how they will be using or not the technology or engaging with it or not. Another thing was technical issues have emerged, and this was like the first launch of the app. So, but when that happened, participants tended to blame themselves for it. So maybe I'm not using the app correctly. So this self-blame attitude is really something that we want to avoid, right? Like we are introducing technology for mental health, but then we're increasing this kind of self-blame attitude and negative attitude. So this had a negative impact on their experience. And finally, I'm concerned about sharing my data, self-report data. So the self-report data was shared if the person wanted to their therapist, but people commented, I'm not sure that I would necessarily want my clinician to be kind of big brothering me on my sleeping trends, or I would want to work out some days, but my body has no energy. I can't go and explain it to someone why I feel that way because that is how I feel. It's okay if my therapist has my self-report data, but I don't want any questions asked as to why. So as you can imagine, this will have impact on design, and I'm going to address that in the next part. So when we have all these kind of comments and testimonies, we want them to do something with them and have an impact, a positive impact on design. So design implications is an outcome of this study. So there's a full list of design guidelines in the paper, which I can share with you at the end if you want. I'm just going to go over a few of them. So in terms of what I've just mentioned there, so the healthcare professional relationship, like we want really to have a compassionate use of self-report data. And we want to be transparent on that with the user, that your data is not going to be used in a judgmental way. You're not going to be kept accountable for, like not exercising or going to bed too late. So compassionate use of self-report data. In terms of self-image, so we want to create mental health technologies that are non-stigmatizing, because stigma is such an important factor for not engaging with technology. It really has to be non-stigmatizing, but also technology that empowers people if they want to speak out about their mental health. So someone commented that they had the smartwatch and they got a notification and they actually felt comfortable sharing that with their friends. And this was like a conversation opener and opening about her mental health. So we want to actually navigate, this being non-stigmatizing, but also, if we can, empower users to speak out. And then in terms of usability, so there is a fine line between try to minimize demands placed on users. So typically automating self-report. But as you do that, you don't want to take away the self-awareness that people build when they are doing self-report manually. So logging their sleep manually, that would bring their attention to it. But if it's automated, that might take away, that building self-awareness. So it is a fine line to navigate. In terms of other takeaways, so on the theory aspect, the factors that came up are not all covered by the validated models. So there is obviously a gap in theory that needs to be addressed. In terms of methods, we do need this longitudinal view and repeated measurements to measure user acceptance. So this means study that would be spanning over, depending on the technology, but spanning over a period of time anyway. But which time points? When are you going to measure these factors, basically? And then mixed methods is something that I would really argue for, because from just having questionnaire scores, you're not getting a real insight into people's lived experience. So, okay, their acceptance is high, but why is it high? Maybe that will change in the future. So just having an understanding of what is important to them and what has led it to be high or low, that is really important to understand. And then, so to evaluate acceptance in clinical settings, there's lots of logistics involved, ethics approval, recruitment of patients, there's some training and risk management to be aware of or to learn. So it is typically more difficult to do, and you typically need partnership with a healthcare provider. So to wrap up this talk, in terms of future work, we will need to revise and advance acceptance theories for the reasons I mentioned, typically to integrate that temporal dimension that is currently not addressed in the models, which are quite static, investigating the context that are underexplored or the new context of use of technology that are not yet covered by theory. In terms of supporting design, so something that's important is to address user acceptance in the design process and not just wait that the technology is out there to then, get an interest into it. So anticipating issues, but also anticipating what might facilitate uptake and facilitate use of technology at design stage. And then educating on the factors, so getting people to understand what those factors are. That is not just one thing, it's actually a set of things. And then the temporal dimension, that acceptance might be high at the start, but people might encounter obstacles and it might actually decrease, and then they might just give up the technology. And finally, supporting evaluation in real settings to get a real understanding of what's going on. So capturing a rich picture of user acceptance through using mixed methods and talking to people. Adopting a longitudinal approach, so repeating measurement, measuring it over time, and then considering the broader interventional context. So in terms of digital therapy, it's not just people using the smartwatch. It's people using the smartwatch and using digital therapy, which is something that will carry with it other acceptance issues, right? Particularly for people who have never done it before. So just to keep in mind that the context in healthcare, it's often broader than just a particular piece of technology or equipment or device that you're looking at. So yeah, thank you very much, and I'm happy to take any questions.
Thanks so much, Camille. Again, don't forget to review and follow us. And if you want to get in contact with us, you can by emailing us at humaninthemachinepodcast@gmail.com. All that's left for me to say is, I've been Ben Cowan, stay curious, and don't let the machines get you down. Until next time.